Today we're talking about the post-acute care response to the COVID-19 pandemic. I'm Mike Bush, VP of Growth and Strategy for eviCore's post-acute care program. I've been in the industry for more than 30 years, first as a payer myself, and then working for organizations like eviCore.
I'm Yvette Lefebvre, Chief Medical Director for Post-Acute Care, DME, and Sleep Services at eviCore Healthcare. My clinical specialty is in emergency medicine. I've been working in the world of Medicare compliance and utilization management for 10 years now. I've been working with eviCore for a little over 3.5 years now. And I'm coming in from my home in New Jersey today, where we're in our 8th week of our stay-at-home order. So that explains the long hair.
And I'm Dan Tews, Senior Vice President and General Manager of eviCore's Post-Acute Care Program. I've been with eviCore now for over 20 years. I've been in the post-acute care space for 30 years plus. Don't want to date myself too much, but I currently oversee the post-acute care program at eviCore Healthcare.
So my colleagues and I have a unique perspective on the situation, and it's a real privilege to share it with you here today. We'll look at the situation from both clinical and business perspectives, how things have changed, and what the new normal will look like once the storm passes over. Dan, to start with, help us understand how post-acute care as an offering here at eviCore operates normally in a non-pandemic environment.
Well, we typically do, for all of our clients, current clients, we do a full risk model on a population designated by that health plan. We look back, prior to starting the program, we look back 3 years of full claims data. We then set a benchmark for guaranteed medical savings to the health plan. We set that benchmark based on the last 12 months of spend on all the areas in which we are taking risk for. We do, our program includes doing all management of inpatient post-acute care services. So that could be skilled nursing facilities, inpatient rehab, or long-term care hospitals. It also includes management of home health services, as well as durable medical equipment and sleep supplies and studies. So it's a very comprehensive program. And what we do is our management really includes all prior authorizations and level of care recommendations following an acute care stay or coming directly out of the community. We also then do continued care reviews within post-acute care settings, whether that be at a skilled nursing facility or home health services or wherever that patient is receiving the care. And then we do have a transitions of care program outreach for up to 90 days to ensure that our members are receiving the appropriate safe care throughout their recovery period while minimizing risk for avoidable readmissions. So that's pretty much it in a nutshell, Mike.
Well, thanks, Dan. I appreciate that. Now, let me ask the same question to Dr. Lefebvre, but from a clinical perspective. In other words, how do you and your staff operate with providers, patients, and caregivers in a normal environment?
Sure. So as Dan mentioned, our normal process includes performing medical necessity reviews on all requests for both admission to post-acute care facilities, as well as doing concurrent reviews or continued stay reviews on patients while they're receiving post-acute care, whether that's in a facility or home health services. To assist with those processes, we have nurse care coordinators who actually go on site to some of our higher volume post-acute care facilities. And again, under normal circumstances, we also have social workers that go on site to both some of our acute care facilities and our post-acute care facilities. Two of our key components, I would say, for our post-acute care program are our case conferences and our concurrent reviews. Those are two mechanisms we utilize to ensure that our members are receiving the right care in the right place, and that careful, appropriate discharge planning is occurring throughout that post-acute care period in order to avoid those readmissions that you guys were mentioning earlier. So we actually have a team that consists of a nurse care coordinator, a social worker, and a medical director who all meet on a weekly basis to discuss every patient who's receiving care in a post-acute care facility in order to discuss their complex medical issues, their ongoing care, their discharge plans, and any barriers to a safe discharge that might be identified. And so those are kind of a couple of the key components to our normal processes.
Great. Well, thank you. Now, as a follow-up, how have we seen it change? How's post-acute care delivery changed for us from a clinical perspective in light of this pandemic?
Right. So pretty much everything I just mentioned has been kind of flipped on its head, obviously, over the last couple of months now, right? One of the big changes we all noticed early on in this pandemic was that patients started almost immediately opting to go home, right after an acute care stay, or if they were in a skilled nursing facility or an inpatient rehab, they were wanting to go home sooner than later, right? A lot of that probably tied into fear, right? There's just that normal understanding that if you're at home with only your immediate family members coming and going, you're being exposed to fewer germs, right? Than you are in a facility where there are maybe hundreds of people coming and going on a daily basis. And part of it also just probably ties into just, that security of being in your home, right? When there's a global crisis going on, there's a feeling of, I want to be in my personal space with my family. I just feel safer there. And there were upsides and downsides to that, right? The upside is absolutely, when someone is in their own personal home, there is less exposure to infections, right? Whether it's COVID-19 or whether it's our normal run-of-the-mill influenza, there's just less exposure. But there certainly are risks, right? If a patient goes home after a prolonged hospital stay where they've become debilitated, there's a significant risk for falls if they're going home in kind of a weakened state. Wow. There's also risk, right, with medications, right? If you're going home, especially if you're going home alone after a hospital stay where maybe you've had new medications started, and you might get a little confused. Am I supposed to keep taking all these other medications? Am I just supposed to take my new one? How often do I take my new one? So there's a risk of medication errors, and that's not insignificant, especially if you're looking at an elderly population. And then things as simple as meals, right? You go home, again, especially an elderly person, debilitated after a hospital stay, goes directly home. Just making meals and getting proper nutrition can be a challenge. Adding on top of that, right, we had an increased number of patients opting to go home rather than to post-acute care facilities. Compounding that issue, we then started running into difficulty coordinating home health care because our home health care agencies started running into issues with their staff getting sick. Staff was going into homes, they were getting exposed to COVID-19, and all of a sudden we had a shortage of home health providers available. On top of that, the providers that were not sick and were available to go into homes were facing a shortage of personal protective equipment early on. So we kind of had a whole lot of challenges piling on top of each other early on in this crisis. On a more personal level, within eviCore ourselves, we had to deal with just a logistics approach like every other company did, right? All of our team members had to start working remotely, whether they were used to that or not. All of those on-site nurses and on-site social workers had to be pulled out of those facilities quickly. We completed that transition in early March. And then, as Dan and I were both saying, doing those medical necessity prior auth reviews is kind of a key component of our program. And we decreased the number of those reviews significantly early on. And so then we ran into issues with figuring out where our members were, right? Trying to find out, patients were moving from hospitals to post-acute care settings, and we weren't quite sure where they were. So a lot of our nurses were just kind of cold calling our facilities saying, hey, do you have any of our patients there that we can help you out with discharge planning? So a lot of changes in a short amount of time, that's for sure.
Wow. Wow, that's amazing. It really is like a frontline battle. So let's turn things to the business side now. Dan, what have we seen so far in terms of our payer clients' reaction to the pandemic?
Well, I think it's been interesting. I think as a society, I think all of us were not prepared for what we've all been through now over the last 3 or 4 months, particularly in the New York area where we have our largest client membership Yeah, obviously along with the lack of testing and shortages of PPE and all the things we hear about all the time, there was the enormous number of hospitalizations that occurred, again, particularly in the New York City area and around New York City. ICU beds were short. There was a real difficulty in finding safe settings for patients to recover. While, they or a family support member may actually be compromised. So what we tried to do for our clients as a third-party manager, if you will, we tried to help our clients stay ahead of all the legislative recommendations in terms of lifting PA, et cetera, because we had a prior authorization, because we had an overall philosophy that we felt it was important that we keep hospital beds open, as many hospital beds open as possible for new COVID diagnoses. As most of you know, elective surgeries and other things had been canceled, right? So there were a lot fewer patients, and because of the lack of movement, people staying at home, less trauma. So there were a lot fewer non-COVID patients coming into the hospital, but you still needed a lot of beds for this sort of onslaught of COVID positive patients that we saw through March and April in the New York area. So it was important we keep those beds open. So we had, were kind of ahead of the state and federal recommendations to lift prior authorizations, patients coming out of the hospitals. But what we did think was important was that we wanted to continue to preserve those valuable post-acute care resources. And we continue to do concurrent review on a somewhat maybe a little bit more of a limited basis, but working with the providers, whether they be skilled nursing facilities, inpatient rehab facilities, or home health providers, to make sure that we got that patient into the right setting, the safest setting possible, and that we also made sure that we could move that patient safely home, because that's really what our objective was to be able to get that patient, and always has been, to the least restrictive level of care. And moving a patient home nowadays is so important because, as we've seen, there's a lot of risk of patients being in facilities, whether it be a hospital or nursing home. I know the nursing homes have taken a lot of scrutiny from the media, but really I think there was a real unavoidable situation that occurred in the New York area where you had so many patients who were being infected within nursing homes, and some of that was coming in from visitors before visitation was stopped, or coming in from employees who were bringing in from the community, as well as COVID positive patients that were being admitted into nursing facilities. And it was very, very hard to control the spread of the virus within those facilities. So it became really important that we tried to create a better, more robust home health program. And we're still in the process of doing that. And we're coordinating with some of the larger home health providers in the market. We're coordinating with various telehealth solutions that we're looking at, that we're working with. One of the solutions that we work with, we actually did a IVR call-out survey for all of our members that we were following in our transitions of care program, to make sure that they were not being impacted by COVID, whether they were COVID positive, or if a family member had become ill, their support system had become ill, so that we could make sure that they were getting in touch with their physician providers, that they were getting the right home health services that they required. Because what's happened in this whole shelter-in-place environment is that patients who are at home are not getting the same access they used to healthcare. So we felt it was really important, partnering with our telemonitoring partners, to be able to do that additional outreach. And in fact, we shifted a lot of our staff that had previously been doing prior authorizations coming out of the hospitals. We shifted that staff into our transitions of care team, so that we could be sure to have a lot of folks available to help and work with patients. And our staff in those areas includes nurses, it includes social workers, and folks who can really help these patients and be sure that these patients are getting access to the care and are involved in their own treatment plan and or have the support that they need to remain at home and remain safe. So that's really what we've done as a group. And so from the business perspective, we've really shifted our focus from the front end prior authorization piece more to the transitions of care side.
Got it.
And making sure that we're managing those patients safely and getting them home as much as we can.
Oh, that's great.
Yeah.
That's great that we've been able to be so responsive to the situation. I think that's a real positive.